Hello, good evening, everybody. I think I take a chance to start the webinar, and good evening, everybody. Really, we are happy to have a chance to stay a little bit together. I know that nowadays this is the only way we can really share our experience and try to spend some time together. I hope that this situation will get better in the next future and we will have a chance to see each other physically. I would like, if you can move on the next, I would like to thank personally on behalf of ESSM, IBSA. They are doing a fantastic job, not only in the market, but moving and promoting the educational activities, not only with our societies, but overall around the world. And I think that they really deserve to have as we will see today, really the best communication, the best educational program we can do. ESSM have to thanks on our side the organizer of this webinar, in the person of Mikkel Ford, that is our educational chairman, and Giovanni Corona, that is our scientific chairman. Both of them has done a fantastic job, not only in order to find the most attractive and interesting topics to be discussed, but also promoting a survey and all these kind of scientific activities that were organized by IBSA and ESSM. Now, with regard of ESSM, just 2-3 slides to give you a little bit of a picture of what we are actually doing in terms of educational projects. First of all, I want to introduce to all of you the ESSM Academy on Genital Surgery. This is for us a very important new project that it will start in the second part of this year. And it is a complete important learning program to improve not only the knowledge, but also the skills of surgeons, and in order to try to make it possible to grow up in the genital surgery in the best way. How do we do that? We decided to have 4 different levels, and we will start from online webinars, moving then to textbook and video library. At this stage, all the attendees will then move in the real surgery that will start with a 3D model, moving then to the real fellowship in our important centers of excellence. So this is an important project for us, and you will see this advertised in our website after summertime. Also, we have another important project that is more scientific and is about the scientific collaboration and partnership. This ESCAP project aims to connect basically the expert of sexual medicine from all the different sexual societies with the young people, the young talent authors, and we hope to be able to create an important collaboration in order to produce not only good papers, but also to improve the skills of these young authors. And we have already done the first paper that is nowadays already submitted, and it has been done by a young Italian fellow, but of course helped by an expert one. Another important project that we are running at the moment is to try to update, and we are already working in this direction, our 2 Bible, that is the Manual of Sexual Medicine and the Syllabus on Clinical Sexology. As you know, they are very important for us, not only because they are important as a textbook to cover and to give knowledge about different aspects of sexual medicine and also clinical sexology, but they are also very important because, as you know, they are the texts that people use to prepare for the exam for the qualification in sexual medicine, that it would be next time in Rotterdam in 2022. In fact, my last slides will be actually with regard of this next important appointment for us, that would be in February 17 to 19, 2022 in Rotterdam. And of course, we all hope to have a physical meeting and to come back to our normal activities. And so we look forward really to see all of you next in this important meeting and to spend time together and have a nice day together. So thank you very much for the moment. I'm quite pleased now to leave the chair to Mikkel, that he will introduce our speakers that are very well known. Thank you very much.
Thank you very much, Carlo. Very appreciated. So tonight's webinar is on news and future of ED treatments. And as you could read on the website, this is going to be on a new oral dispensable PDE5 inhibitor, but also about more experimental treatments, including shockwave therapy, stem cells, and platelet-rich plasma. So I think it'll be a very interesting seminar tonight, sponsored by IBSA, and we're very grateful for this support to be able to bring you this important information. Now, I feel like these webinars that we've been doing for almost a year now keep getting better and better. And every time I introduce it, I feel like this is going to be the best webinar so far. Tonight, we have two very excellent speakers. They don't need much introduction in ESSM context. The first one is going to be Giovanni Corona. This is our scientific chair for the ESSM, and he is from the endocrinology unit in Bologna. Has written hundreds of papers and really an impressive researcher and clinicians in this field. Our second speaker is Michael Lewstarovich from Warsaw, Poland, also very well known, has been a part of the ESSM for a long time, giving numerous talks, writing, again, an impressive amount of papers on these topics. And he is a professor of psychiatry in his department in Poland. So without taking more time from this, it's my great pleasure to introduce the webinar tonight. Now, for all the participants, I just want to say there will be some questions and answers after the presentations. So if you have questions during the talks, please put them either in the question and answers or in the chat box, and we'll collect them and ask the questions as we have time when the talks have finished. Also, please remember to fill out the survey once the webinar is done. So for the first speaker, Giovanni, please.
So thank you, Mikkel. Let me try to share my screen. Okay. Thank you. Good evening to everybody. I'd like to thank again IBSA for supporting our educational activity. And tonight, as you have heard, we are going to address a very important topic, so possible novelty for ED treatment. During my talk, I will analyze possible news regarding PDE5 inhibitors. So PDE5 inhibitors are quite known, the first-line therapy for any patients seeking medical care for erectile dysfunction, and this is the recommendation coming from the International Consultation for Sexual Medicines. And this is also recognized by the new European Association of Urology guidelines published last week, 2021. Again, PDE5 inhibitors are the first-line therapy option. Very interesting, during last ESSM virtual event, we performed a web survey among the physicians involved in the event. And again, this comes from the real practice. So the vast majority of the physicians declare that PDE5 inhibitors are the first-line therapy. Despite their efficacy and their safety, the discontinuation rate of PDE5 inhibitors is still very high. This is a paper coming from 2006 addressing only sildenafil dropout, and as you can see, it was reported an overall dropout of about 40%. Just 6 years later, other survey, including sildenafil, vardenafil, and tadalafil, and dropout was quite similar, about 50%. So the dropout is still very, very high. Accordingly, in this meta-analysis that we published some years ago, we were able to demonstrate that the monthly dropout rate is about 4%, meaning that in 1 year, about 50% of the patients who were prescribed any kind of PDE5 inhibitors abandoned their therapy. And as expected, I have no time to go through, we also found that the dropout was particularly higher in younger subjects, probably due to a psychogenic problem, or in more complicated ones. So those reporting a higher prevalence of associated morbidities. What are the main reasons of these conditions? Essentially, in our meta-analysis, we identified the 6 different reasons leading to an important dropout. And as you can see from the error bars, all factors play an independent role in determining the dropout. So 6 factors were identified. How can we manage this situation? How can we improve? How can we reduce the dropout? Essentially, in our opinion, through 2 different actions. With better information, either for the patients and for the physician, and with new technologies. What about information? This is a very old paper, published almost 20 years ago, a telephone survey regarding the contact between patients suffering from ED and their physician. And as you can see, even if ED problems lasted more than 3 years, more than 40% of the patients did not contact, did not interact with their physician. Some years later, 2014, again another, in this case, web survey. So 68% of the patients with ED did not use medication, and only half of them had a close relationship with their physician. So even after almost 20 years of PDE5 inhibitors era, again, the vast majority of the patients use not to contact or not to interact with their physician. So a large number of patients with ED do not seek medical care for the problem. Similar data published by our group, a large number of web survey, including patients who declared at least the use of one-time PDE5 inhibitors in the previous 3 months. And as you can see, the vast majority of the patients, 60% of the patients, did not report a formal diagnosis of erectile dysfunction. 40% self-reported ED, and 11% did not report any kind of erectile dysfunction, even if they declare the use of PDE5 inhibitors. So the vast majority of the patients with ED did not receive a formal diagnosis. As expected, the patients who received the formal diagnosis were older and had a higher prevalence of associated morbidities, in particular, in this case, high risk of diabetes. So essentially, patients who received a formal diagnosis of erectile dysfunction use PDE5 inhibitors to improve their problems, so to increase the hardness of the erection, to gratify the partners. They receive the prescription by the physician, and they used to buy the drug to the official pharmacy. Conversely, the other people, so people who did not receive a formal diagnosis of ED, use in more cases the drugs just for curiosity or to try. So the patient who received a formal diagnosis used to buy the drugs in the official pharmacy, and the drugs was prescribed by the general physician. Again, essentially to summarize these important concepts, we identified two different kinds of people using PDA5. The first one, the large majority of them, at least coming from this survey, called it the performance, who were younger, healthier, not received a formal diagnosis of ED, and used PDA5 inhibitors just for curiosity in vast majority of the cases, buying them online, so in the black market. This is very important, considering the possible side effect deriving from this kind of behavior, and conversely, patients who were older, more associated morbidities, and prescribed by their general physician. So better information is still required even after 20 years after the launch of the first PDA5 inhibitors. What about new technologies? One of the most important factors leading to a dropout, which was identified as one of the main conditions leading to an higher dropout of PDA5 inhibitors, was related to the possible presence of side effects. Accordingly, in this Delphi consensus that we perform among a large number of andrologists in Italy, published 2 years ago, there was a quite general agreement, so a good agreement, 90% of the agreement, that tolerability is one of the most important factors to be considered before selecting the different kind of PDA5 inhibitor. So tolerability is one of the most important factors for PDA5 prescription. Very, very interesting data coming from our ESSM survey. The efficacy was another important factor, so the restoration of natural sexual act and the efficacy, and even another important factor, so the convenience of intake. So other two important factors to be considered are the effectiveness of the drugs and the convenience. The second area, so the second modality of PDA5 inhibitors after the launch of the film-coated tablet was related to the oral dispersible tablet formulation. And this study is a pharmacokinetic study considering sildenafil, showing that the bioequivalence of the two different kinds of formulation was quite similar. And again, similar data were thereafter also reported for vardenafil. So ODT formulation shows similar drug bioavailability and similar incidence of side effect. What is the next generation? So the next generation of PDA5 inhibitors. Next generation is the oral film formulation. As you can see from this slide, very, very easy to carry and to administrate. Oral films do not require water or swallowing, can be perceived as with a faster onset of action by the patient and even by the physician, and avoiding the first pass metabolism can potentially increase bioavailability and reduce the incidence of side effect. Now we have a pool, so Danny, if you can launch the pool, I have to maybe interrupt. So now I invite you to answer to these questions. Are you familiar with the new orodispersible film of sildenafil? Yes or no? Please vote. This is a new kind of formulation available in some European countries. It is several years that is available in Italy, so we are going to discuss about this new kind of PDE5 inhibitors, sildenafil formulation.
Thank you so much for voting. Just a few more seconds, and I will share the results.
Thank you, Danny. So as you can see here, the vast majority of the physicians, the vast majority of the colleagues of us involved in this webinar was not aware about this new kind of formulation. So let's talk about share again the screen. Okay. Okay. So the data were quite similar during our web survey. At that time, about 50% of the physicians were not aware possible advantage of this new kind of formulation. So let's talk about it. This is a pharmacokinetic study comparing oral dispersible film of sildenafil 100 milligram and film-coated tablet of sildenafil. And as you can see, the bioavailability, considering the sildenafil concentration, are essentially the same, and even considering the most important sildenafil metabolite. Oral dispersible films, when compared to oral dispersible tablet, can allow different advantages. Convenience, and as you have seen, this is one of the most important factors to be considered for PDE5 inhibitor prescription. Convenience for the administration and convenience also for packagings and for carry. The large surface area can allow a rapid disintegration and dissolution in the buccal cavity, so this can be perceived with a faster of action when compared to the oral dispersible tablet or film-coated tablet. Easy to transport and store it, and as I told you, the possible reduction of hepatic first pass can increase the bioavailability and reduce the incidence of side effects. In addition, this kind of formulation, this is true for any kind of drug, are usually preferred by the patients. The only point that should be tested is the taste. That can be, in some cases, is important to evaluate. So oral dispersible films can have several advantages when compared to oral dispersible tablet and film-coated tablets. Another important pharmacokinetic issue is related to the how to use the drug. So the approved method of administration is above the tange, but this kind of study compared the administration below or above the tangent. As you can see, the pharmacokinetics, considering sildenafil concentration and the main metabolite, were essentially the same. So no difference between the two different kinds of administration. But what are the outcomes essentially? This is a phase 4 study performed in Italy, comparing the film-coated tablet for 4 weeks, sildenafil 100 milligrams, 2 weeks of washout, and sildenafil 75 milligrams oral dispersible films for 4 weeks. And as you can see, the data with several domains of IIF were similar, but looking at the overall satisfaction, the score showed a significantly higher score in the oral dispersible films when compared to traditional tablet. So better overall satisfaction when compared to traditional tablet. And this is the feeling coming from the ESSM survey. As you can see, these are the feeling from a physician who already prescribed this kind of drug. Faster, so again, faster onset of action, the impression of faster onset of action, the convenience, and the discretion of the medicine. And this is, I think, the most important. The vast majority of the patient, more of the physician, more than 90% of the physician who have already prescribed the drug, essentially were convinced to further prescribe the drugs in the futures. Any other news regarding PDA5? Yes. Again, new technology. The nanotechnologies is a quite complicated bioengineer approach that can improve the administration of several drugs in different ways. And one of these ways is the topical delivery. Are there any data with PDA5 inhibitors? Yes, mainly derived from animal studies. These are data from tadalafil in rat, and as you can see, this is the intracavernosal pressure and blood pressure after electrical stimulation before and after tadalafil topical administration that can increase intracavernosal pressure. What about vardenafil? Similar data, even as you can see, potentially the transdermal administration can potentially increase the bioavailability, so the plasma concentration. Similar data again with sildenafil. The area under the curve is potentially higher with this kind of formulation, but again, data from animal model, and the same for avanafil. So new technology can improve PDA5 outcomes. So finally, my conclusion, PDA5 inhibitors represent the first-line therapy for ED. However, their dropout is still very high. Next generation of PDA5 inhibitors, in particular oral dispersible films, can allow to improve PDA5 in outcomes, improving patients' good perception and physician good perception, and reducing dropout. And I thank you for your attention. Mikkel.
So, thank you very much, Giovanni, for your precious presentation. I think we can now proceed with Mikkel. So go ahead.
Okay, so just let me share my screen.
All right, we can see your presentation perfectly.
Thank you very much. And so welcome everybody. And I would like to tell you a few words about possible new approaches for the ED treatment. As it was mentioned already by Giovanni Corona, there are several new roads regarding PDA5 inhibitors. And we may ask ourselves a question, do we need new approaches for ED treatment, as we have highly efficient PDA5 inhibitors that are the first-line treatment, as well as we have highly efficient second and third-line treatments, as for instance represented by the intracavernosal injections of vasoactive agents or inflatable penile prostheses. But on the other hand, why do we search for alternative options? First is the search of a longer effect durability, longer on-demand PDA5 inhibitors or injection therapy. The second reason is a search for less invasive options according to intracavernosal injections that will be repeated many times, or the penile prosthesis that will require surgery. And the third thing is still a search of drugs with favorable safety, tolerability, and of course, acceptance from the patients. And these are the three candidates I would like to talk about today. These are the low-intensity shockwave therapy, the stem cell therapy, and platelet-rich plasma therapies. But first, I would like to ask you a full question. Are you familiar with the low-intensity shockwave therapy?
Thank you so much for voting. Let me just allow another few seconds and then I will share the results.
So let's see the results. As we can expect, the majority, almost 70%, has answered that you know it from the literature. But some people use it in clinical practice, and a very little percentage is involved in the research. So thank you for voting. So let me explain in a brief sorry, I cannot operate. Okay, now it's working. So what are the shock waves? To make it simple, these are the longitudinal acoustic waves that can propagate through water or soft tissue, similarly to ultrasounds. And given extracorporally, they would have a minimal tissue absorption and no thermal effect, which is also related with potential safety of these procedures. There are different protocols regarding numbers of sessions or the frequency, and as well as the generator used, which can be focused or linear. The most commonly used is focused, and this is the most commonly represented in different studies. And the expected effect of shockwave is the increase in smooth muscle and the endothelial content in the corpora cavernosa. And there are few mechanisms involved in this process, which is an upregulation of angiogenic factors that are stimulated by shear stress. Then it's the recruitment of endogenous mesenchymal stem cells and the stimulated regeneration of endothelium, neuronal nitric oxide synthase positive nerves, and the smooth muscle tissue. And the third one will be induced nerve regeneration by enhancing the recruitment and the activation of the progenitor Schwann cells after the cavernous nerve injury. And there is about a decade of research behind the use of shockwave therapy. In one of the first experiments from 2000, this is a publication from 2010 by Vardy, there were 20 middle-aged men with vasculogenic ED. And what was noted after 1 month follow-up after the therapy, the significant increase in erectile function domain of the EAF in all men. And this also was recorded as unchanged at 6 months. Half of from this group also did not require any further PDE5 therapy. There were also increase in the duration of erection and penile rigidity. It was perceived safe, no pain was reported, no important adverse event as well. So this was very promising. There is also another more recent paper from 2019, which is actually the clinical recommendation from the European Society of Sexual Medicine on low-intensity shockwave therapy in sexual medicine. And what it shows, so summarizing research in the field, that we have several studies that has given quite different outcomes about the improvement of erectile function, mostly as they were compared by the sham therapy, sham controlled therapies, but it was very rarely that it was described in detail what was the sham. As you can see here, as for instance, the device in the off mode, but serving the sounds of the original working instrument, for instance. And there were only 2 studies that compare different protocols, like 6 sessions versus 12 or 18 or 5 versus 10 sessions as comparators. These studies were also investigated according to the risk of bias, and basically 2 of these studies has prevented against most important sources of bias. So, for instance, using random sequence generation or allocation concealment, blinding participant and personnel, only in 1 case blinding also the outcome assessment. And here are the meta-analyses that investigated LISWT. And as you can see, there are 5 papers on that. And in fact, 2 meta-analyses included heterogeneous population that consisted from ED patients, but also with concomitant Peyronie's disease or chronic pelvic pain syndrome. And only 2 of them has included solely randomized control studies. And the reported overall difference in the erectile function domain of the IAF was approximately 2.5 points in the analysis by Mann et al. And it was 4.2 in the one by Clavillo et al. It was both, they were favoring the shockwave therapy treated men. But also in the latter one, there was a pooled analysis of 5 randomized control studies that was included, and this resulted in a double inclusion of positive trials. So this could cause an overestimation of the effect size. Let me ask you another question. So when we often use the self-reported outcomes, and the most commonly used scale is the EAF, and especially erectile function domain regarding the assessment of erectile dysfunction and improvement of the therapy. So please answer, how do you perceive, what is the minimal increase in this domain score that can be considered as clinically meaningful difference?
Thank you so much. So another few seconds so that we can collect the last results.
All right, so here are the results. Almost a half has pointed 4 points as clinically meaningful difference. So in fact, I must say that all of you are right, but under some conditions. Here is a study. Here is a paper from 2011 regarding the interpretation of the EF results, and it provides a parameter of a minimal clinically important difference, which was assessed, which was evaluated using the receiver operator's operating characteristic based measure, and it was calculated that the MCID for all group of the patients with ED being treated would be around 4 points. But if we divide them into subgroups of different severity of erectile dysfunction, you would see that for men with mild ED, the minimally significant change would be 2 points. With moderate erectile dysfunction would be about 5, and severe, that would be about 7 points. So we have also keep this in mind while analyzing the results and see what kind of a population has been treated and evaluated in particular studies. So here, for instance, we have a comparison of the protocols and follow-ups of shockwave therapies that you could see, for instance, after 1 month follow-up, the subtotal change was evaluated at 1.19 point. The 3 months follow-up was here, let me see, that was a subtotal of, this is given the percentage, I don't see it, but there is a 6, the total for all of these measures would be around 2. So now you can easily interpret using the minimally clinical important changes, seeing that these changes are really not so much significant. And this was also reflected by the ESSM committee recommendations. Regarding the assessment of patient-reported outcomes, the current evidence is promising but still very controversial. So a clear clinical recommendation of LI's SWT for ED cannot be made, and we need more high-quality studies. Regarding penile hemodynamics, it was shown that Shockwave improved penile hemodynamic in patients with vasculogenic ED, but there are still uncertainties about the clinical long-term significance of this improvement. And regarding the effect endurance, there were variable effects of Shockwave on erectile function up to 12 months. So still we need more data to assess the longer-term effects. We have no studies comparing 2 treatment methods using linear or focused generator, and we still cannot give any recommendation or suggestions regarding specific protocols. Still, there is not enough data comparing different protocols of the treatment. The optimistic information, however, is that this kind of intervention was proved very safe and well-tolerated procedure, which may encourage clinicians and researchers for more trials and assessing for maybe targeting patients which may have the most benefits from this way of treatment. And here are the European Association of Urology guidelines that show the use of low-intensity shockwave treatment in patients with mild vasculogenic ED. That can be an alternative for the first-line therapies for well-informed patients who do not wish or they are not suitable for oral vasoactive therapy, or they desire a curable option. And it can be also considered in patients who are poor responders to PDE5 inhibitors, but still the grade of recommendation is perceived weak. And these questions raised are quite similar to that given from the ESSM paper. Now, the stem cell therapy, which is most commonly mesenchymal stem cells that are used intracavernosally, and they are considered a potential therapy to restore the injured cavernous nerve due to their paracrine effect on the surrounding penile tissue and the differentiation into smooth muscle, endothelium, and neuronal tissues. Here is the collected data from 20 studies on animals from almost 250 rats. They show the increase of intracavernosal pressure to medial arterial pressure ratio, as well as increased neuronal nitric oxide synthase, smooth muscle ratio, and the ratio of smooth muscle to collagen, showing all quite a promising potential of this way of treatment. And so the preclinical data show us the potential of improvement regarding mainly the structure changes that may lead to the improvement of erectile function. But 5 studies with blinded outcome assessment were in that case significantly less effective than the unblinded studies. So we have to take this into consideration and see that this might cause the detection bias, and the treatment efficacy might be in that case overestimated. So we need more rough data. And here are trials on humans, with the first reported clinical trial of stem cell therapy in diabetic men with ED that showed a reasonable increase in penile rigidity after one single intracavernosal injection, or there were umbilical cord blood stem cells. So while the penile rigidity was maintained for more than 6 months, the erection was not hard enough for sexual penetration in that case. So the single administration was likely insufficient. In a different study on the use of stem cells in men with ED following radical prostatectomy, it was a study from 2017, it shown that intracavernous injection of bone marrow mononuclear cells that appear safe and improved erectile function for a period of 6 months. But decline in erectile function over time suggests that repeated intracavernosal injections should be assessed as well. Here, another very small open label phase 1 clinical trial. There were only 4 patients, showing the improvement in patient-related outcomes, the erectile function domain, lasting for about 12 months, but only in 2 of patients, the hardness, erection hardness score persisted up until month 12. So at this moment, we can conclude that there are some possible improvements from preclinical data. We have only preliminary results in human. So this initial optimism regarding very rapid translation of stem cell therapy to clinical evidence-based practice has slowed down a little bit. There are concerned and lack of clear longer-term effects in humans. And we have to think whether this is also the matter of ED pathogenesis. So maybe for some patients it might work, and it might be more tailored treatment, and maybe a potential for combination therapies in treatment-resistant ED, as it can be combined with any other treatment protocols, for instance, using the first-line therapy as PDE5 inhibitors. And now just a few slides about the platelet-rich plasma, which is chemically composed of highly concentrated platelets and plasma proteins that are produced from the centrifugation of the whole blood. And these therapies, platelets-rich therapies, are being used in some other medical specialties since long. For instance, it was used to improve the angiogenesis and wound healing. This kind of treatment could theoretically improve also urogenital conditions as erectile dysfunction or Peyronie's disease or stress urinary incontinence. But a concern with plasma-rich proteins, however, is also its early washout. This is a situation that might be potentially avoided by conversion to the platelet-rich fibrin matrix, which is also investigated. As here in this study on rats, there were 4 groups, one that underwent sham operation and 3 other groups after crush injury that were treated afterwards. First subgroup with application of the general platelet-rich plasma, the other one with optimized platelet-rich plasma with the largest amount of the platelet-derived growth factors, and the third one using normal saline-only injection. As you could see here on this graph, that the optimized PRP shown the beneficial results as they were quite comparable to the sham conditions, so without crush injury. Here is the human report, so human treatment report. And there is a retrospective design of the study with prospective data analysis of 17 patients that received at average 2 injections of platelet-rich fibrin matrix, but the range was from 1 to 8 injections. But we also have to bear in mind that these were a very heterogeneous group of patients. So 11 of them were just Peyronie's disease, and 5 of them was erectile dysfunction. In 4 cases, that was purely organic erectile dysfunction, and in 1 case, coexisting with Peyronie's disease. So among the small subgroup of ED patients, including also the one with Peyronie's disease, patient has improved in EF5 scores on the average of 4.14 after the PRFM therapy, which can be considered a quite important change. But still, this is a very, very small group, so very, very preliminary report. So today there are no treatments that would address the underlying cause on endothelial dysfunction. Therefore, the platelet-derived therapies that are targeting inflammation and that promote the tissue regeneration may represent such a potential treatment option. So although the limited data suggests their efficacy, we still need placebo-controlled studies to confirm the preliminary findings, so we need more evidence-based medicine data. And this is my last slide, so I thank you very much for your attention.
Thank you very much for both of the speakers for these really excellent presentations. Going through, I think, very clinically relevant and very important topics. We have just a few questions, most of them to begin with for Giovanni. The first one, is there already a PDE5 inhibitor for topical use?
The data are coming from just animal models. We have no data in humans. The data are quite old, so not replaced yet. So indeed, from animal model, it seems to work, but obviously we need to have data in humans because humans are not rats.
Okay, that's true. Second question, is there a difference between the time of onset to get an erection between oral dispensable and oral PDE5 inhibitors? And how long is the oral dispensable ones?
Yeah, essentially the pharmacokinetic study shows that there is a bioequivalence between 2 different kind of formulation. However, the way of administration in the tank, so the rapid dissolution within the cavity, the oral cavity, can be perceived as faster by the patient and by the physician. So the patient can report it to the physician, but there are no pharmacokinetic studies showing that these kind of drugs can have a better a faster effect, but can be perceived faster due to the specific way of the administration, and the duration is similar.
Okay, so more a subjective thing. And then finally, a question is a little more general, but it's asking you to outline briefly the use of PDE5 inhibitors in younger men with psychogenic erectile dysfunction.
So indeed, if we can use the PDE5 inhibitors in younger men with psychogenic ED, you mean? So probably, yeah, I think we can use a combination therapy. So within the SSM, we are producing the new statement by Marieke on specific this topic. So I think that there are no many data, but there are still growing. So probably the combination, though the psychosocial approach and not just the psychogenic or the medical approach can work better. So the combination of psychological approach and medical approach, so the use of PDE5 inhibitors can work and can work better, but not just giving PDE5 and that's it. This is not the case.
Okay, and as she was saying, there's another paper coming out from the scientific committee of the ESSM recommending on the topic. That's very nice. Michael, a question for you. These treatments, shockwaves and stem cells and platelet-rich plasma even, they're not really new. Shockwaves we've been talking about for more than 10 years now, and stem cells, it seems forever, and platelet-rich plasma, is being used several places. How come we're not really getting good data and convincing data? Do you have a guess for that?
So I think there is still a long route of research to get all this data. As you can see, as that was the initially very optimistic results that were not so much confirmed in more evidence-based strict protocols. So it happened very often with these methods that we begin with open labels. We begin with very preliminary reports that show a lot of, probably also a lot of placebo effect and the rater bias. I don't really know if it's still such a long research, in that maybe this is the case that first that was not non-selective inclusion of the patient. That might be also, and that what I was trying to mention in my talk, that maybe we need a more selective competition of the cases that should be treated with this option. For instance, this is also the case with microvascular surgeries, but I'm not an expert in that, but as far as I know, it may be used for very, very selected patient group that may have some benefit from that, but for the majority, it would not be the case. And so maybe this is the for further research. I don't know what, maybe you have some more comments about being here. Urologists as well.
For the shockwaves or the surgery?
Yeah, shockwaves.
For the shockwaves, my perception is that if you do an open label study on anything related to ED, you're usually going to have good results. And if you have people come in and pay for treatment, you're usually going to have very, very positive outcomes for the treatments because there's such a big psychogenic component always, as Giovanni was saying, in erectile dysfunction. So I think for something like this, it's extremely important to have a control group and have the study very well controlled. And I think that's one of the challenges, especially with shockwaves, to have patients really believe and providers really believe that they're giving a placebo treatment in these studies. I think it's something that we're not discussing. I think this is a very challenging thing. We're getting past 9. Carlo, do you have some final comments?
No, I'll say that your comment is perfect because we've got the same feeling when we started to do PD5 trials and PD5 inhibitor trials in 1995, 6, 7, whatever it was. And so this is the real comments that when you got in this sort of disease or condition, then you find that the real number of placebo success rate was really very, very high, higher than 40%. It was amazing. So that's correct.
And it really underlines that this is a biopsychosocial problem, I think, and we need to look at the whole patient. I think it's nice from an ESSM perspective. This is what our association is trying to do. I want to thank all the participants. I want to thank the speakers, Giovanni and Michael, and I want to thank Danny for, again, helping to organize this excellent symposium. Mr. President, do you have some final words before we close?
I just want to really thank everybody, and thanks IBSA, because they gave us a good chance to talk about these very interesting topics. And I hope to see all of you next for the next webinar. Thank you, Mikkel, for organizing all of this with Giovanni. Thank you very much.
Have a good night. Bye-bye.
Bye.
Thank you, everybody. Thank you for having attended our meeting. I just wrote in the chat, please remember to fill out the survey that will be submitted upon closing the session. Thank you so much.